I would like to ask you guys to sort of stretch in your chairs, right? Roll your shoulders back. Big breath. And as we go into the next session, I have a request of all of you. So the first request that I have is to think about where do we each as individuals fit into this work? What is our role? What are we bringing to the work? What is our story? Secondly, to make sure that we're listening to all these speakers as if they're wise, because there's an immense amount of expertise in the room. Third is try to put yourself in the situation of that boy and his grandmother who came to the emergency room, who's sitting there in an unfamiliar territory seeking help, and all they're getting are roadblocks and barriers for hours, hundreds of hours. Think about the dynamics of power and privilege that are playing out there. Think about how it would feel if it was you and your child seeking help, and is that the response you would get? And then lastly, think about how we're going to continue to be accountable to ourselves, to our communities, and to our organizations as we push this agenda forward. So I would like to welcome the next panel to the stage. And as panelists, as you come up, please come up in the order that you are in the agenda. I will remind you if you need a reminder. Jason Helgerson, then Juliet Price, Francesca Gray, and Peg King. So we now have the opportunity to really hone in to a panel of leaders who are actually leveraging Medicaid dollars for kindergarten readiness. And they come from 3 different states, New York, Georgia, and Oregon. And I would like to introduce their very wise and sagacious speaker, who in and of herself is a leader in philanthropy and has an immense amount of expertise in the field. So Myra Alvarez is the president of the Children's Partnership, which is a national nonprofit working to ensure that all children have the resources and opportunities they need to grow up and lead productive lives. Alvarez recently finished a several-year stint on assignment for the U.S. Department of Health and Human Services. She was most recently the director of the State Exchange Group for the Center for Consumer Services. Ms. Alvarez led the team responsible for supporting states in the establishment of the health insurance marketplaces, including state-based marketplaces, state partnership marketplaces, and federally facilitated marketplaces. Her list of accomplishments is numerous. She began her professional career as a health policy fellow under then Senator Barack Obama, and she completed her education in the School of Public Health at the University of North Carolina at Chapel Hill, and her undergraduate education at University of California, Berkeley. Great people come out of the Bay Area. So thank you very much.
Thank you. Good morning, everybody. Yes, I'm Myra Alvarez. I'm the new president of the Children's Partnership. We are a national children's advocacy organization that specifically focuses on creating opportunity for kids by ensuring access to healthcare and access to technology. For 20 years, we've worked to identify issues on the horizon for kids in order to better direct our work toward leveling the playing field for every child and ensuring that we can provide the most impact for their well-being. And I think innovation in Medicaid is a primary example of how we can do just that. Because across the aisle, regardless of party, we can all agree that children are a priority. When the Affordable Care Act was enacted and the Children's Partnership was preparing in California for the first open enrollment period, we created a partnership with the California Department of Education to utilize the important role that schools play in the lives of families. Through our All In for Health partnership, we've been able to distribute enrollment information and tips about how to use their coverage to families through a trusted resource, schools. Regardless if it's a low-income family, families of color, immigrant families, time and time again, we hear that schools are a trusted source of information, particularly when it comes to health information. The key slogan in our campaign that is clear with our agenda today is that healthy students make better learners. And with the growing number of children enrolled in Medicaid, it's more important than ever to find ways to align these efforts. It's really hard to overstate the importance of Medicaid. It insures 77 million people and pays for more than half of all births in our country. In California, almost 6 in 10 of our 9 million kids are enrolled in Medi-Cal, our state Medicaid program. These are children that rely on the program to see a doctor when they get sick, to get vaccinations and screenings to keep them healthy. And as Vicki mentioned, that critical EPSDT benefit really offers children a comprehensive package of services to ensure they're healthy at every stage of life. As a result, studies show that kids with Medicaid coverage show up at school ready to learn. They're less likely to drop out of high school, more likely to graduate from college, more likely to grow up to be healthy, productive adults, really showing a return on investment to a critical government program. It's a proven program that's going to make a difference in lives of kids today and the lives of adults tomorrow. Health really is connected to every aspect of our lives. On a national level, you can look at any of our biggest goals as a country, whether that's creating jobs, helping kids succeed in school, building stronger communities. Health is connected to every one of those goals. And on an individual level, health is fundamental to opportunity, especially when it's talking about kids and ensuring they can reach their full potential. So how do we ensure this critical connection between our Medicaid system and our education community in order to maximize the impact coverage can have? With us today, we have a great panel to help us learn how certain states are utilizing their Medicaid program to better prepare children early in life and put them on that trajectory towards success. So let's get started. I'm privileged to have the opportunity to moderate today's discussion around how states can leverage the Medicaid program. And like others have said, take this opportunity to learn from my panelists and be able to take that information back to our home states. With me, I have a distinguished group of panelists that each brings a unique perspective to this work. Today, we'll hear from Jason Helgerson, Medicaid Director for the state of New York, a position he's held since January 2011. New York's Medicaid program provides vital healthcare services to over 6.2 million New Yorkers with an annual budget in excess of $60 billion. He also serves as the executive director for New York's Medicaid redesign team to lower cost and redesign quality in the program. This effort was recently recognized as an Innovation in American Government finalist by the Harvard Kennedy School of Government. And the same year, Jason was recognized as a Public Official of the Year by Governing Magazine. After Jason, we will hear from Juliette Price, the director of the Albany Promise, a cross-sector collaborative impact partnership of over 100 institutions in Albany, New York, that facilitates the improvement of educational outcomes for the city's most vulnerable students using a shared vision, collective action, and rigorous continuous improvement. It focuses on 6 key outcome areas that we'll talk about throughout the day today. And recently, Juliette was awarded the White House Champion of Change Award for her work in this field. When Juliette concludes her remarks, we'll have the opportunity to listen to Francesca Gary, president of AmeriGroup Georgia, a wholly owned subsidiary of Anthem. In this role, she's responsible for all aspects of AmeriGroup health plan operations in Georgia, ensuring that members receive access to high quality care and strengthening relationships in the community with both the state and among providers. She has more than 19 years of leadership and industry experience in public programs like Medicaid and Medicare, but also commercial products. And finally, we will have the pleasure of hearing from Peg King, the Kindergarten Readiness Project Manager at HealthShare Oregon, the state's largest coordinated care organization. Previous to Peg's work managing HealthShare Oregon's strategic initiatives in kindergarten readiness, she worked at the Oregon Pediatric Society, managing statewide trainings for pediatric providers. So let's get started. Jason?
Thank you. All right. Well, certainly it's a pleasure to be here, and I'll say for 2 reasons. First and foremost, it's a pleasure because my career actually started in K-12 education policy with a focus on early childhood education. And while I've been in healthcare for over 10 years, it's really great to be at a meeting where we can talk about the synergies between these 2 fields. And I think we have a tremendous amount that we can do together to improve the lives of children all across the United States. And secondly, I'm glad to be here because I'm not talking about the repeal of the Affordable Care Act or block grants or any of those things that are the outcomes of the election. So I am so happy to be able to talk about something else. All right. So with that, as mentioned, New York has the 2nd largest Medicaid program in the country with over 6 million people and a budget that exceeds $60 billion. We used to be the largest program in the country. We were happy to give that title to the state of California, which has a much larger population. But we, unlike California, our actual issues and challenges that we faced and Governor Cuomo faced when we took office was we actually spent twice the national average on a per recipient basis, yet we were not getting the kind of outcomes one would expect. And in fact, back in 2009, a Commonwealth study found that New York ranked dead last in the nation when it came to what I consider one of the most important metrics of a healthcare system, which is avoidable hospital use, which means our system as a whole was not serving patients very well, particularly the chronically ill in our society. And as a result, individuals were showing up in the hospital when they really shouldn't be. And what that did was it led the governor to a multi-year transformation effort that you could sort of summarize in 3 steps. The first step was to try to get the Medicaid program in our state to be more efficient, to adopt more effective policies that are more effective, more going to be impactful in terms of better outcomes at a lower cost. That was really where we started in 2011. In the first 2 to 3 years, a lot of focus there. Great success. We've improved outcomes overall as a program, and our per recipient spending is down. In fact, we've reduced it now to less than 2,000. We spend less now on a per recipient basis than we spent in the year 2000. The second phase, which is where we are today, which is to say that, and I would say that the state has crossed a few Rubicons in our efforts in terms of redesign. One of the first Rubicons we crossed was an acknowledgement at the end of the day that if we wanted a more cost-effective delivery system in our state, if we wanted the Medicaid program, which is just one purchaser of many, to be able to purchase services in an effective fashion, we had to do something about the underlying delivery system, which wasn't generating the outcomes of the costs anyone should expect. And that's what our delivery system reform incentive payment program is about. It's about trying to get providers from across the sector, and I say provider in a very general way, which includes not just healthcare providers, but community-based organizations, local governments, to come together to focus on better outcomes for the community, both in terms of the healthcare system as well as public health. Those have been formed into 25, we call them performing provider systems. You'll hear about Oregon's version of the CCO, which is very similar, and you're seeing that there are other states that are also pursuing this route. That's our very ambitious effort. Over 100,000 organizations are participating in DSRIP in various forms, so it's a very ambitious effort. The next step, the step actually we already are beginning, is the move to value-based payment. It's important. In fact, Vicki saved me from having to define what value-based payment is. I appreciate the question and the answer, but it's really important that we have the healthcare system in the United States, in my view. The one we have is a reflection of how we've paid for care, which is we spend about 17% of our wealth as a nation on healthcare, yet our outcomes, which is far greater than any country in the world, yet our outcomes are more akin to what you would see in Eastern European nations and even in parts of the developing world. And that, I believe, is because we pay for units of service and we don't pay for outcomes. We don't pay when providers do a good job, and we don't pay when the community's health improves. And value-based payment really is about fundamentally changing those financial incentives to get providers to work together as teams with not just healthcare providers, but the rest of their communities to address the core challenges that they face. And that's what value-based payment is. Now, what I would say about value-based payment, and I say this generally about the social determinants of health, is that I sometimes think of it for the healthcare sector, we're being a little selfish. Why? Because we're asking other organizations, other sectors to come join us in our efforts to help us achieve our goals. But what I would say is that healthcare is, and in many cases, the largest economic engine in communities across this country. And actually, we have an obligation not just to work towards better health outcomes and a healthier population, but to actually begin to systematically address other outcomes that a society should care desperately about. Obviously, we're here talking about early childhood education. We're here about making sure children enter school ready to learn, and that ultimately they're successful in school and life. But I would argue there are other metrics that collectively we, as individual systems, right, our own silos, and while we've been in healthcare trying to break down silos within our system, there are other silos that exist between healthcare and education, healthcare and early childhood, healthcare and juvenile justice, healthcare and the broader criminal justice system, the economic development systems, the housing systems. We all run different systems that touch the same families, the same lives, yet rarely do you see opportunities for those kind of conversations. You'll hear from Juliet in a little while about one of the efforts we're trying to do, but what we're trying to do in New York is to actually begin to try to mobilize the healthcare delivery system as an agent for change beyond just healthcare metrics, but actually to start embracing other metrics that are essential. And I think that, to me, would be the power, the excitement of how you could leverage Medicaid as the largest human service program left in our country as a powerful agent for change beyond just healthcare metrics. So what are some of those metrics? Kindergarten readiness, that's where we're focusing today, is how can we begin to use the healthcare value-based payment context to actually drive change. And for us in healthcare, the big thing we're doing, and this is where we're working with the Albany Promise, is that we want to get to a point where pediatricians are actually paid more when the children that they serve enter school ready to learn. We want reimbursement to healthcare providers to actually be linked to societal outcomes that really, really matter. That is no small change. That's why I say, to a great extent, we have crossing with this new way of thinking, a new Rubicon. Another effort to embrace those social determinants, to brace them not just to achieve healthcare metrics, but to actually improve society. But one could go even beyond that, to start thinking about measuring quality of life, measuring overall mortality, and, God forbid, community happiness. Right? So people always laugh at me in the healthcare world when I talk about we're going to make everybody happy. But if you actually think about it, it's probably one of the more powerful predictors of overall community success. And I think we need to start thinking beyond even some of the traditional metrics that we look at, to start thinking beyond what should we really be focused on as a society. How should we really evaluate ourselves beyond things like employment and median income and disparities in some of the traditional ways, to start thinking about communities and sub-communities and things like community happiness. So I'm a big believer that some of these metrics, and in fact I would argue particularly in early childhood education, the reasons why we have not achieved great success, the reasons why we still have many miles to go, is because our challenges here are cross-sector. They are cross-system, and whenever you come across a challenge in which no single system is accountable for a result, what you are going to find is generally results that are not what anyone would want or accept. The fact that in Albany and in New York State today, 40% of children roughly are entering the school system not ready to learn, and we know that that is a tremendous predictor of lifetime success, and yet that statistic remains constant over a long period of time, is to me an indication that we are not yet coordinating across these systems. We are not yet having these community-wide conversations, and that's what we're trying to do with regards to Albany Promise. It is not easy. It is very difficult to get these sectors to work together, to begin to embrace each other's objectives, not just in a sort of, as I say, in a selfish way, asking others to join our table to achieve our objectives, but to actually begin to embrace those measures that affect. But I think at the end of the day, this to me is the great challenge of the next 10 to 20 years. Can we, in communities all across the state, stop thinking about just education outcomes, stop thinking just about healthcare outcomes, stop thinking just about housing outcomes, and begin to have community-wide conversations about all of those outcomes and what we can collectively do together? If we can foster that, and back to the funders in the room, if you can foster those conversations in communities across the state to bring those sectors together, that would be a very powerful use of your resources. So in terms of this future state, I think Medicaid can and should play a leadership role in this. We do not, and we have broad shoulders, and we do have policies and procedures and things that can help drive the kind of innovation I'm talking about at the local level. We can't do it ourselves, but we have to identify ways, and that's why I think in the early childhood space, in the school readiness space, where, as was mentioned with EPSDT and others, we have unique responsibilities. We have an ability to touch children and families as a system, as a sector, that drives us in why we should really look to this as an area. But we need to look beyond our areas. We need to think about successful collaborations. And while we do not have all the answers in New York, we are very interested in learning from others across the country as we collectively move in this, I think, very exciting direction. So that, I'm happy to turn it over to my colleague, Juliet Price.
Jason, I think you stole the clicker here.
Oh, there you go.
Gotta watch out for that guy. All right. Oh, I'm sorry. Okay, good morning. My name is Juliet Price. I lead the Albany Promise. We're a cross-sector partnership located in Albany, New York, which is the capital of New York. I know it's surprising to folks from New York City. And I think before I even get started, I think there's already a question that has already been formed in Polly, so appreciated your comments. Because I think there is, more and more people are thinking about this new way of thinking. So once you get people there, once you get people to understand this is a cross-sector work, the biggest question I get asked, how do you do this? How do you actually make these things happen, right? Because these are great conversations to have, but as Jason just stated, it is very, very tricky. This is one way of going about it. So we are a cradle-to-career partnership, which means that we actually bring together all sectors in our community. We have about 12 sectors represented. I could tell you a little bit more about what we look like if you're interested. But we actually have embraced this concept that there is no silver bullet. We could provide the best high-quality pre-K education to every single child in the city of Albany. And if that is not followed up by really great instruction from K-3, we have seen nationally that those results diminish. And then we're back to third grade reading not being where it is. We come from a community where 14% of our third graders are reading on grade level. That's 14.14. So we have a huge issue in front of us. But if we don't do better there, our children obviously are socially promoted. We end up with an 8th grade math problem. We know that 8th grade math is a telltale sign of college and career readiness. We know that if they don't pass 8th grade math, which is Algebra 1, they typically do not graduate high school. If you don't graduate high school, you don't go on to post-secondary to your 4-year training programs, whatever you may be. If you don't get into a post-secondary institution, you sure can't complete. And if you can't complete, you can't get a job. So for some reason, we've decided to embrace all of this and say, you know what, we're going to look at it all. So that's one part of how we go about this. So I think today we can really start talking about how do we actually do this? What does it actually look like? So I'm just going to give you a peek into one area of our work. So we've been working in early childhood. Our outcome area here is kindergarten readiness. This is nothing that you don't already know. We just always start with the basics. We've been working in early childhood for about 3 years now, and we really started with 4-year-olds, and we said, what could we do in that 4-year-old space, really around expanding pre-K, high quality, making sure it's the highest quality it can possibly be. In our second year, we expanded into 3-year-olds and said, well, why don't we open up some more EPK slots? And it was really that conversation with our EPK and our pre-K providers where they said, you know, there is something funny going on here. Once we had built that trust, they said there's something funny going on. We're seeing kids who should have been caught earlier. They have significant developmental delays, but they should have been caught earlier. But our problem is, as a 3-year-old or a 4-year-old provider, this is where we first see them. So we can identify this, but it doesn't really help because, as so many other people have noted, the earlier you figure it out, the earlier you identify it, the earlier you connect with services, the better chance you have of really helping that child. And so they said, you know, we're in our lane, but we can only do so much. And we said, yeah, we hear you on that. So we started talking about developmental identification and intervention. And in the state of New York, we have early intervention, as in many states. But really what we were hearing was there wasn't a universal strategy, at least in our city and our county, to make sure that everyone was having access to this initiative and these services at the county level. So we sort of said, we looked at each other for a really long time and we said, okay, well, it feels like we're still missing someone. And so we started thinking about how could healthcare help? And this is just a really, I think, easy way to start thinking about it, is that if you move from sort of 4 to 5 backwards, we have a lot of our 4-year-olds, we have near universal pre-K, we have some of our 3-year-olds, but then when you get into those 3, 2, 1, we're really not seeing them. They're really not in the education space, if you will. And so we had to start thinking about, well, where are they? And we started thinking about, well, they're showing up for well child visits because of the immunizations. We have a great partner in the state Medicaid program. So we started asking some basic questions, some basic data questions. How many children show up for their well child visit at age 3, at age 2, at age 1? We noted that they were very exceptionally high numbers. So this all of a sudden was a real leverage point for us. And we said, well, here's something we might be able to try. This was talked about a little bit earlier, and Vicki touched on it, and Paul touched on it too, is that just because there's a policy, that is a really great place to start, right? All of this early screening, I know the president of AAP is here or will be here later. They're issued guidelines, all of these kinds of things. But really the world that I live in is the difference between knowledge that something can work. We know that early screening works. But the difference in how you actually see it implemented and work across different sectors and spaces. That is not that's a Grand Canyon, actually. We have enough information about what evidence says works. What we don't have is enough understanding and knowledge about how to make it work across different contexts. That's really important because that really lies at the heart of what everyone here is trying to do. And I'll get back to how the funders can help us bridge that divide. So when we looked at improving the identification, we looked at who was actually getting referred into EI. And there was a really troubling piece of information that we discovered. There was a complete racial flip in who was being referred and screened by EI. So we live in a county where about 2/3 of our population is black, 1/3 is white. The folks who were getting into EI, 2/3 of them were white, 1/3 was black. And so we realized that there was a real racial issue that we were facing, and we needed to fix it in a more universal strategy. Okay, so this brings us to our project, which I'm going to go over at a very high level. I'm happy to take questions about it here or a little bit later. We've temporarily called it All Kids Ready. We're working on that, guys. So really what it is it's a project that we're launching actually as we speak, and it's really a coordination of many, many entities, but as you see, it's really centered around kids. So we have parents and families involved, we have the managed care plans involved, we have pediatricians, our early childhood community, our Albany County Early Intervention Services is run through our county, our city school district, and of course our Medicaid program. So these are all the players that are involved. Again, this gets to the how you do this and just how complicated this is. So this is a little bit of, this is our structure. This is a simplified process map that I wanted to share with you. In this new model, parents will be attending their regularly scheduled well child visits. They will be participating in the ASQ3, completing that in their pediatrician offices. We've developed some processes to make sure that pediatricians are talking about this with the families, properly referring to EI. Our county has gone to a single point of entry system, so all of the referrals will go to one place, be sorted out there in terms of those who need to go to the preschool committee on special ed versus those who are eligible for EI. They will make their way through the EI system. What we've also built in are feedback loops, data feedback loops. That way the EI system is talking back to pediatricians about what happened. Was the child eligible? Was the child not eligible? What else happened? And then the managed care plans are also going to help us really make sure that every child comes in for every single visit, so we see them and we track this over time. We are following the AAP guidelines of the 9, 18, and 30-month marks, so we're hoping that every single child would get every single one of those screenings. I know someone asked a question earlier about how do you ensure that that works. So to funders, leveraging Medicaid is such a good idea. It's such a good way to go. I think my biggest thing to funders would to be able to say that doesn't happen on its own. We don't just, right, like school teachers, school administrators do not just bump into Medicaid directors at the supermarket and just start talking about this. I don't know. I mean, Jason, yeah, I don't know. So to Jason's point, there has to be the infrastructure for this. And I was saying this kind of off the cuff yesterday, but I guess I'll say it again. Medicaid doesn't need any more funding from the private sector. They can't take it. That's not how it works. But what you can fund is the civic infrastructure like organizations like mine and so many others to help us get there. Because the other second question I get so much about this project is like, well, how did you convince Medicaid to do that? With data. We had the infrastructure to say, hey guys, there's a problem here. Look at this, not the kids who should be getting these, who really, really are most vulnerable, need these services, they're not getting it. We had the expertise. We had all of that infrastructure built. It's a lot easier to say yes when there's significant infrastructure there rather than someone who comes to you and says, I think there might be a problem, maybe, I don't know how bad the problem is, and frankly, I don't really know what we're gonna do to fix it. So funders, invest in your local infrastructure to invest in how we can get to those bigger population level outcomes. And that's all I have to say.
I'm not going to get up to the podium. I'm not a podium type of gal, so my name is Fran Gary. I'm the president and CEO of AmeriGroup Community Care of Georgia. I'm not a policy person. I'm definitely not a clinical provider or anything. And what I'm going to talk to you about is sort of our experience and maturation and journey as a Group Community Care, particularly with our foster care program, and how that program has impacted our overall program, but also given us a focus on 0 to 5 and readiness for kindergarten. So we'll start from there. And give me grace on some of my numbers. I'm also an introvert, so to be in front of all of you gets my heart rate going, so I apologize. It's not a big thing, but I am really passionate about this, and I think it's really important. So about a couple of years ago, so first of all, there are 3 CMOs in the state of Georgia. AmeriGroup is one of those CMOs. We have 385,000 members. There are 2 programs. One is called GF, which has TANF CHIP members, and it's GF 360, which has foster care. About a couple of years ago, in 14, the state of Georgia made the decision to have all foster care children, including adoption assistants and DOJ children, moved into managed care. They made a unique decision, which was to take the total program and put it into one managed care organization. And AmeriGroup was chosen, and then we were rechosen just last year for another 5 years. And so that sort of makes sense, because you think, wow, okay, managed care companies have these core competencies of, claims and network and access and care coordination, and so, let's have foster care children in that program. Okay, so we got these 27,000 children, and about, at the time, about 7,000 of them, about 7 or 8 were foster care. The rest were adoption assistants. And that means they've been adopted, but the state is providing some assistance. And I don't mean to be basic. You all know this. I'm not as probably policy as all of you all, so forgive me if I explain things you already know. And so what was interesting is, and so what's interesting actually is now, so there's 7,000, then 2.5 years later, we have 15,000 in foster care. It's doubled. And so that's an interesting dynamic. But so we have these children, and we put them into the process and the system that we have. And we're stunned, right? We're stunned because we thought, oh, what you do is you do EPSDT, you do dental, you do vision, coordinate care, you got it, right? No, you don't have it. And what we found is the third leg of the stool that is unusual, and as you talk about what managed care companies can do, or Medicaid, and I'll talk from a managed care standpoint, it's the social leg of the stool. And that has not been something that we have played in or been part in, even in managed Medicaid. And so this foster care population really sort of threw us on our heels, because we had to understand the social determinants, and that before we could get to the EPSDT and the dental and the vision and all those things, that we really needed to know the social things. We needed to help with those. That was a big learning curve. And so just to give you a perspective, for us in the foster care children, we have 42% of those children are 0 to 5. It's a very significant amount of children. And in our non-foster care, 32% are 0 to 5. And so as we began to see that there were greater social needs, we began to go out to our community-based partners. Because again, and this is just me and probably Georgia, I have a fundamental belief. We know things we do well as a healthcare plan, and we know things that community do well. And if we bring those together, we might do some really great stuff, right? But part of it was just to educate us, right? It was to educate us. And so one of the first things that we noticed when we looked at the data, the state gave us a whole bunch of data, was that 0 to 5, 21% of those children were on 1 or more psychotropic drugs. And that was one of the biggest things that we had to look at, because we had a value-based purchasing clause, value-based share in our contract that made us think, wow, that's one of the things we have to get down. And also the state of Georgia was under a Kenny A decree around their EPSDT levels and getting children into dentist and vision. And so we had to solve for that. So we started to go to schools. We started to go to primary care providers to have conversations. One of the most interesting things at the schools was, you know what, we've got behavioral issues. We just send the kids out and we ask them to give them something and we'll bring them back. So we thought, wow, okay, got to think about that. And then we heard, oh, you know what happens? Kids go, they don't have any food over the weekend, they come back, they're not focused. We get behavioral issues, we send them to the doctor, we give them drugs, and we bring them back. And I thought, wow, right? So we've got all these teams that are dealing with this stuff, right? How do we deal with that stuff? And so one of the things that we did when we brought all the community partners together is say, help us understand what this means and what the delivery system needs to be to support the children. Then they said, oh no, not just to support the children, to support the families and the caregivers. That's a big switch, everybody, for a Medicaid health plan, right? And so, yes, you can leverage Medicaid, but there's also, for some of these Medicaid managed care companies, a big learning curve, right, that has to happen. And I believe when I think about the funders here, one of the biggest things that you can do is invest in community-based partners, because we do not do in Georgia what we do if we did not have our community-based partners. So let me go through the things that we were focused on. We realized that one of the keys that we needed was early diagnoses. We needed early diagnoses. Another thing we needed was early interventions. And the other thing that we learned is we needed to reach the children and the caregivers where they are. We thought the first year people would come. They'd come to their doctors. We were paying more for access. We were doing a lot of things. And we didn't see increased utilization of people going to the primary care physician, to the pediatrician, to the dentist. And what we found is when you talk to the foster care mother who has 8 or 9 kids, and they're different ages, and we have an aging foster care parent group in Georgia, 60, 61, if she got to take one, she got to take them all. And so therefore, we're going to miss that appointment. And so then we began to use all these vans that were paid for years by community dollars sitting in places with the FQHCs, and began to take them to the DFACS offices. We began to take them to schools, Tier 1 schools. We began to take them to the Ys. We began to take them where kids play basketball. We began to take them to the communities that we knew had the gaps of what needed to be solved for. Just the quick stuff, EPSDT, dental and vision, right? We're just talking about those things right now. And in this last year and a half, we've seen the rates double for people accessing EPSDT, dental and vision services. So we got the idea, how about a van to do developmental assessments? Put some clinical behavioral folks on there, they agree to it, create a program around that. We did that. Then we spread out to all the children in foster care, that every child, and to all the caregivers, that any child should have developmental assessments. That was a change. The state agreed to pay for that. That was a change. So we worked with the state when they began to say this stuff. The other thing that we did was we realized when we were talking to the schools, good nutrition. So we said, okay, we'll work with another community partner who said, we will help you bring food to the schools for the kids to take home for the weekends. And in two-gallon Ziploc bags, we put 6 meals every weekend in over 21 Tier 1 schools, right? And kids can put them in their backpack so there's no stigma, and they have food for the weekend. And now we're testing that because that's been going on for 6 months to see what the outcome is when the kids come to school on Monday. So we've put some measures around that. So some things that the schools asked us to do, that's been really important. The other thing we've invested in is telemedicine. What we heard was we have these school-based clinics. But they're not being used because we don't have nurses, we don't have this, we don't know how to fund them. How can we use them to immediately sometimes not have children leave school, but right there maybe see somebody get services? And so we've made a commitment over the next 3 years to put telemedicine suites in all the Tier 1 schools. The state has worked with us. We're working with Department of Education for the state of Georgia, and Anthem Air Group is going to help fund that over this next 3 years, including the staffing and the folks. It's been amazing, and I jump for joy because we just got our first claim where a child went because they had a behavioral issue, immediately went to the telemedicine site that we set up in this Tier 1 school. Someone interfaced them with the behavioral, and they were able to just work with that child immediately. These are just things, no big things. I mean, not probably big policy, but they're really things that are impacting whether children are going to be able to stay in school and be successful from 0 to 5. Better perinatal health. So again, 2-generation. You can't talk about just the kids and not talk about the moms. And we really started working with the NICUs around talk with baby language and practices, and now we've gotten 2 or 3 of the major hospital NICUs to train all their nurses on that. We've trained all of our nurses. We're working with the other CMOs to do the same and to train all the members that we engage with to talk with baby protocols as well as practices so that we can really just affect how they engage in their perinatal care and with their children. We've engaged resource mothers, doulas, to go right into the community where people are and they're pregnant and engage with them. So these are just basic things that are helping out. Last thing I want to talk about, so I don't take up all the time, is infant care interventions. So oral health, critical. We only used to evaluate at age 3 and up. Now we've moved that back to age 1. So any child age 1, we'll start them on oral health intervention. We started doing summer nutritions, weekend nutritional programs because we wanted kids to still be focused on reading in areas that are related to where our foster kids are. And as I told you, all kids had development assessment. The last thing that I want to bring to point is that what you said, which is critical, is you've got to bring everybody together. And one of the things we realized in doing all this, after year 1, we were tired. We were like, wow, this social stuff is something else, right? Like, whoa, right? Because we just pay claims and we do this, and this is a lot of stuff, right? And a brilliant woman who is in the room, Arian Weldon over there, partnered with me and said, Fran, let's create a 0 to 5 work group. And what we're going to do is bring together Department of Public Health, Emory University, Easter Seals, Head Start, RPA or DCH, the Department of Community Health, Department of Behavioral Health, all these people who have common things that they want to do around 0 to 5. Show them the data that you have. Because a lot of them don't get time to do their own data, believe it or not. Show them the data of these outcomes and these numbers where children 0 to 5, less than 30% have had EPSDTs, or dental screens and all that. And how can we collectively come together to work? And over the last couple of years, it has helped not only define policy, to make changes to things that the state has agreed to pay for, or to help us get access to the school systems. It's just been amazing, to the point that I want to bring this last one up, that we have now garnered with Emory University and the state to agree to help us to put together a informational database that sort of can inform, give us some predictive modeling, right? So we're going to have birth information, children's health information, we're going to have their school information, we're going to have the information of their families, and in fact the state has agreed to allow us to put our information attached to a student ID, so now all the data is in one state longitudinal data system. And now, that's incredible, and it's incredible because we can now, in maybe a year or 2, look and say, okay, what are the big drivers? And knowing those drivers allow us to say what health interventions can we tailor, right, to ensure the success of children from 0 to 5 and any children. So there's a lot more things I could talk about, but anyway, I would say the major thing is you got to help managed care companies shift their paradigm. You've got to help them. And I look at the funders in here to say the people that help do that are the community-based partners. And the need to come together and be disruptive and innovative is really important. The other thing is to challenge our state partners to break out of this is the way we've always done it, right? And here's all that we can do. And we all just need to get a little crazy for these kids, right? We just need to get a little crazy and think of things that people have said no to, like being able to put this data in the state system, which nobody ever thought we could. They've been trying to do it for 10 years. But like minds all got together and said, this is aligned with what we need to get done. So those are some of the things I think of. Thank you very much.
I'm not a podium person either, but I'm sick of sitting. So, I'm really happy and excited to be here today with all of you and to learn from all these great panelists. There's a lot of synergy with what you guys are talking about. So I work for Health Share of Oregon, which is the largest CCO in the state of Oregon, serving the Medicaid population, and I run the strategic initiatives around kindergarten readiness for the CCO. So sort of the opposite of what Fran was just saying, the CCO has prioritized kindergarten readiness as one of our 2 strategic focuses over the next couple of years. So they're putting their money where their mouth is up front. And one of the reasons I actually agreed to go work there was because of that strategic focus. I think it's remarkable that a healthcare organization is focusing on kindergarten readiness. So before I share a little bit more about what's happening on the ground, I just wanted to give some very high-level context about healthcare, about what CCOs are. And in 2012, our governor, Kits Haubert, negotiated a waiver with Medicaid to create a new model of accountable care that we call CCOs. So there's 16 regional CCOs in the state that bring together local health plans and community organizations and providers to really transform how healthcare is delivered across the state. So we're really able to think more creatively and differently about who is delivering the healthcare, how is it being delivered, where is it being delivered, and how are we going to pay for this differently, this value-based payment that we've heard people talking about. In order for us to do that, we had to agree to have a global budget that integrates physical, dental, and mental health. We are committed to decreasing the spending trend over the years, which we've successfully done. And we have pay-for-performance metrics that are there to ensure quality and accountability. So importantly, this model shifts the focus from individual health to population healthcare and gives us flexibility in how we spend the dollars. So if we meet the pay-for-performance metrics, funding is released for us to do innovative projects with our community partners across the region. So that's how we're paying for a lot of the kindergarten readiness strategies that I'll talk about. So I think it's really interesting, how did a healthcare organization land on kindergarten readiness? And there were basically 2 drivers. One was, like most CCOs, when we started talking about we needed to control costs. Let's look at the adult high utilizers. Hate that term, but these are the people that frequent the emergency department, have multiple chronic conditions. They're the 5% of our members that cost 50 to 60% of the costs. So we started looking at them, and then through a CMMI grant, we decided we wanted to do a qualitative study and actually talk to these individuals about their lives. So what we found was obvious to everyone in the room. Most of these members had chaotic, unstable childhoods. They were physically and sexually abused. Many were in and out of the foster care system. They had parents who were addicted to drugs and alcohol. In other words, they had childhoods that were not preparing them for school or for life success. So this obviously mirrors what we know from the ACEs research and the emerging neuroscience, that the things that really can derail a healthy life course are things that you can intervene in early childhood: attachment and bonding, skilled parenting, social and emotional help. These are the things that get kids ready for kindergarten. So HealthShare as an organization decided to shift our strategic focus to early life health promotion. Basically, the goal is to prevent the next generation of high utilizers. That was the first driver. The second driver actually is the CCO incentive metrics. themselves. So there are 18 of them. I'm not going to go into them. These are a few of the pediatric focused ones. So we have 18 metrics, and if we meet these metrics, we get a significant amount of money back since we've demonstrated quality that we can use to invest in the community. So the developmental screening metric was really the second avenue that led us to the kindergarten readiness strategy. Obviously, as we've heard, if we can identify a delay early and connect kids and families to services, they're going to be much more ready for kindergarten, whether that's early intervention, whether that's home visiting, whether that's a culturally specific community-based organization. There's a lot of different ways that early intervention can be defined. So we began initially to talk about developmental screening, and like many of these people have said, we convened a lot of community partners, the home visitors, the child care centers, the early learning hubs in our state. Everyone was talking about developmental screening, and we started talking about how many kids are getting screened, where are they getting screened, how often, how are we sharing this data, to your data point. And it really started in kind of an incredible relationship between people that don't normally sit at the table together. And we, as the Medicaid CCO, were able to share some of our data with the partners because we have incredibly rich medical claims data. So this is, here's our developmental screening rate. You can see it's going up. We're above the benchmark. We're going to meet it. We also are able to break that down by race, ethnicity, language, zip code, elementary school catchment area, so we can really do a deep dive into potential places we might want to intervene. So what we found, we decided to disaggregate. We have a big focus on health equity. We decided to look at this by race, ethnicity, and language, and what we found was that although English and Spanish-speaking children were getting screened, kids who spoke Somali, Burmese, Russian, Vietnamese were getting screened at way, way lower rates. So this then prompted another more out into the community, meeting with the refugee organizations and schools and Head Starts and talking about why is this happening. And we're in the process of this now, but we're part of one of the partners we brought to the table is the University of Oregon authors of the ASQ, who are really interested in sort of analyzing and translating the tool into these different languages. But beyond that, how are we messaging this to these communities? Like, what is developmental screening? What is it not? Is it a test? Are you going to take my kids away? That's some of the barriers that we've identified. So this cross-sector group is really working on developing messages with the people in the local communities so that we understand the importance of screening. I won't go into all of this. These are just some of the specific ways we're using the Medicaid pay-for-performance dollars for funding initiatives in the community. We are investing in the Help Me Grow model, which Paul will be excited about, but really trying to build it up in the community and have it sort of be a centralized framework for organizing how kids are screened and then, more importantly, connecting to services. We're also partnering with an elementary school, in a high needs neighborhood, and we're funding a community health worker that we're placing in the school. We're also funding a group of parents there. They're called the community ambassadors. And we're providing training to them to work with the community health worker to go out and create sort of a medical neighborhood and talk to families about the importance of screening, improve health literacy rates. So that's the pilot that's going on for the next year. So it's going to be interesting to track those outcomes. Finally, I won't go through all of these. I was trying to think of what recommendations I would have for funders. I think data paired with stories. What's happened is we've used the data to bring all these unlikely partners together, and it's really catalyzing great conversations and actually system-level change. Because when you get all these people in the room that are dealing with the same kids and families, and you realize how insane and disjointed the system is, so when you're all at the table, you can figure out maybe we don't need 17 care coordinators and 6 home visiting programs, and what. So it's been a really interesting conversation. I think convening the unconventional partners is great. I think funders could provide funding to incentivize this coordination and alignment, similar to, we don't have the Albany Promise, but we're kind of doing it anyway. And then I think patience and time to build trust, because these sectors do not work together. They speak different languages, and I think if you give it time and patience, then the outcomes can be really important. Thank you.
So unfortunately, we're running a little short on time, so we're not going to have time for question and answers. But I did want to thank our panelists and really wrap up with just a couple of summary thoughts. I think there was a recurring theme from each of the panelists focused on the power of convening and the power of listening to the community. You know, you heard Peg talk about the fact that this type of effort is an investment in kids today, but really an investment in the adults that are going to be leading our communities tomorrow. Fran talked about how important it was to listen to the community and inform each other so that we're better responding to the needs of children and families. Juliet talked about the need of funding the infrastructure in our communities in order to make those conversations possible, to make changes to the system. And I think all of that, coupled with the data that we have as resources, I think helps us move the needle on what Jason talked about, an important measure of community happiness. So if we can do that, we're doing the right thing. So thank you very much.
So thank you to all the panelists for sharing their expertise. I know that my stomach is growling, so I would imagine that all of you are super hungry as well. We are going to move into lunch, which is right next door at the 4th Estate. And because we really want to get the work done, we have exactly 35 minutes for lunch, and then we're all going to reconvene. So enjoy some nourishment. Thank you, guys.